Ready? Okay. Hello, everybody again. For the next 45 minutes or so, we're going to talk a little bit about non-invasive ventilation and some of the uses that we have in some complex cardiac physiology. This is not an inclusive talk. This is actually very much an overview. But if you have any questions, again, please feel free, speak up, ask. It helps to clarify things for other people. And it also helps me understand. If you can actually follow my train of thought. Okie doke, once again, I have nothing to disclose. So we're going to talk about non-invasive ventilation. And after this chat, my colleague Katie Reese is going to actually talk about high-flow nasal cannula therapy. So in the spectrum of support for patients, generally we begin with something as simple as O2 therapy, and then conventionally we would move to an intermediate type of support, which might be high-flow nasal cannula. Then we may move along to some type of non-invasive support. And then if we still need more, then we'll move to intubation and advanced types of therapies. So there is, like a lot of things in pediatrics, a paucity of information about non-invasive use. It has commonly been used with adults, and it goes back as far as when we started ventilating fairly regularly back with the polio epidemic. If you think about a non-invasive device as something like this pictured, which is an iron lung, this is the ultimate non-invasive device. By definition, any non-invasive device is a device where we can provide ventilation and therefore gas exchange without using an artificial airway. So without using an endotracheal tube or a laryngeal mask or a tracheostomy. So this is an external negative pressure device. Works fabulously well. It is physiological in that the way that you and I normally breathe is to generate a negative interthoracic pressure, and that creates a pressure differential, which then creates a flow, which then helps us to breathe in. Very simple physiology. Adults began using non-invasive ventilation very commonly back in the 60s, and then neonates, it was an easy application, an easy transition, because we would do it using not just masks, but small nasopharyngeal tubes in the 70s. So now I'm starting to date myself because I was around for some of these things. But now there's widespread use in adults, children, and neonates. We apply non-invasive support to patients with both chronic and acute or acute on chronic disease processes. And we'll talk about a few of the devices and a few of the interfaces. There are a number of different applications that we can use. You can have some of the indications for children would be acute hypoxic respiratory failure. So that means that they're in a position where they have a failure to oxygenate. To facilitate early extubation from invasive ventilation, I wouldn't necessarily say it would be early extubation, but perhaps I would say timely extubation. In neonates, it is not uncommon to try to support patients with non-invasive ventilation in lieu of using an endotracheal tube. That doesn't work as well For children, and the older you get, the less likely we are able to do that in an effective way. But it works really, really well for preterm infants. We use non-invasive ventilation with children that have neuromuscular disease and chronic respiratory insufficiency. The original application for non-invasive support is with obstructive sleep apnea, and that transcends from the adult population, which means that a lot of the devices and the interfaces are designed for adults. This is a huge application and big business for home care companies and respiratory companies. How we have to translate that to provide this kind of therapy to children is interesting, because we really need to adapt what we're doing and understand some of the pitfalls of using adult devices on children. We will use non-invasive ventilation when we have, sometimes when we have upper and or lower airway obstruction, depending upon what the underlying pathology can be. There are things to consider. And what's pertinent to this talk is that we are going to talk about how we use non-invasive ventilation as an adjunct therapy in heart failure for afterload reduction. Over the last 10 years or so, there has been more of an appetite to develop new interfaces and to try to make things more comfortable and more appropriate for children. And the utilization has increased dramatically. Unfortunately, the number of publications that would have gone up with that use has not really caught up. So if anybody's interested in doing some research with children and non-invasive ventilation, it would be a welcome thing. Things that you need to think about. Well, you need to be careful if you've got increasing O2 requirements, because all of these things would suggest that maybe the therapy that you're delivering is not the right therapy, or it's a failure of the therapy. If children that have really bad reflux, you have to think about that. If the child's quite young, they're not in a position, if they've got reflux, to be able to pull masks off the way you or I would be able to do that. So you have to be cognizant of that. Children that have a whole lot of nasal and oral secretions, think of children with, let's pick the obvious one, with RSV bronchiolitis. You can do that, but remember, in order to suction, which is one of the definitive treatments, if you look into the literature for RSV bronchiolitis, suctioning and clearing the nasopharynx is imperative. But in order to do that, when you've got non-invasive therapy, you have to take the mask off, put the mask on, but take the mask off, put the mask back on. That is pretty stressful. Anybody who's not had the opportunity to wear a CPAP or a BiPAP mask, I encourage you to find an opportunity to do that, because until you understand what that feels like, you're not going to understand why a child has such an issue with you trying to strap a mask on their face. You have to be really careful if the child is a post-operative oropharyngeal surgery, like a recent surgery, say a tonsils and adenoidectomy. Those that have craniofacial surgeries, sometimes there's still connections, so you don't want to be putting anything under pressure that can precipitate an embolism. Emphysematous bullae, you can overextend those areas just like you would if you were using regular ventilation. And then again, you need to have caution with pulmonary hypertension with patients with pulmonary hypertension and children that have preload dependent physiology. So in some literature, pulmonary hypertension in itself can be a contraindication. It needs to be balanced with what we're doing and what the outcomes are and how well monitored the children are. Preload dependent physiology, increasing intrathoracic pressure for any child that is preload dependent is something you need to do thoughtfully. It's not a never, but you need to understand the implications. Contraindications are all of these things, and this isn't an extensive list, but the bottom line is if you need to be advancing your therapy, then this isn't the right thing to be doing. So if you've got patients who are in shock, patients who are deteriorating, patients who are having a declining level of consciousness, generally active nasopharyngeal bleeding would be a contraindication. Unrepaired tracheoesophageal fistulas as a general rule is a contraindication. And if you've got really significant vomiting, it's something that you really have to think about. Let's go back to where some of this originated. So this is the iron lung. So it is a whole body device. It is absolutely a non-invasive device. It works by creating negative pressure, and it's applied from the neck down to the sort of the rest of the body. That negative pressure sucks up the thorax. It's pretty simple. And it mimics regular breathing. Well, at some point, you need to, have some nursing care done, maybe a bath or having a bed change. So you can't stay in this all the time. So then these types of devices, these sort of turtle shell type devices are called cuirass devices, are hard shells for which the patients would wear, and they're are attached very simply to something that would be a piston on the back and front stroke. That backward stroke would create a vacuum. That negative pressure would suck up the cuirass device, and again, under negative pressure, would mimic a regular physiological breath. It's fine. I have seen a few patients using this type of device still. They don't come very often in child size. Most of them were for adults, but they absolutely did the trick. Today, we have a wide variety of machines, from things that are developed specifically for non-invasive use commercially to homemade devices. Yep, I really did use one of these things. To portable devices that do all kinds of things, whether it's invasive or non-invasive ventilation. And there are a number of different adjuncts. Some of these are designed for hospital use like this, and some are designed for home use. Interfaces are a challenge. There is no two ways around it. The vast majority of interfaces are like this one, are designed for adults. This is a petite-sized adult mask. It would be a nasal mask, and it is only designed to be a nasal mask. I caution you to not attempt to use an adult nasal mask as a nasal pharyngeal mask, or an oral tracheal mask, as it's more commonly referred to, because first of all, there's not anti-asphyxia safety valves within them. And the other thing is children can't pull them off. So if they were to vomit or felt that there was a problem. As a general rule, they're not able to pull them off. So you need to try to use devices that are specifically designed for children, and there aren't very many. So you can use a device, something like this, but you need to be in a well monitored scenario. And we often use these types of masks. They are called different things, but a total face mask is one of the most common descriptions. And then for those of us who are in the business, we'll refer to this as the scuba mask or the firefighter's mask. Any of those kinds of things that you can use to convince a child to put a mask on their face is always a good thing. So if you need to wear one, or you need to put stickers on your own demo mask, then go ahead and try that. It is a bit of a challenge to try to get a 2-year-old to wear a non-invasive mask. It is incredibly labor intensive. Developmentally, they just don't want something on their face. These are high flow devices. They tend to blow 20, 30, 40 liters of blended gas usually into them. And you can imagine as a child, you don't want that in your face. Unlike with adults, when you're very ill and quite air hungry, you want as much flow as fast as you can. With children, especially small children, if anybody's ever taught a child how to swim, one of the ways you do that is by blowing in their face. There is a reflex, a diving reflex that occurs. They hold their breath. So if I approach a neonate, if I approach a neonate with this high flow device at their face, there is a chance that they're going to hold their breath. That's fine, but if they're in the ICU and they're marginal to begin with, having an apnea and holding their breath and then desaturating creates a whole spiral of events that you're trying to avoid in the first place. Excuse me. So sorry. Here are some other interfaces. So there's the smallest size here. There are some of these that are designed for home, and they're kind of nice, but they're hard to fit. And some manufacturers try very hard. I'm not trying to have you sold on any particular device. Anything that works is what you should use, and things that you're familiar with is what you should use. Okay, so negative pressure devices, I've talked a little bit about this. Here's one for children. Okay, these are quite old. These are from the 50s, this is from the 60s. The manufacture of these doesn't exist anymore, but you might be able to find something that would be similar. Like I said, all equipment is designed for adults. There is no pediatric specific non-invasive machines out there, so you need to adapt what you've got. Things that you need to think about are how much leak is in that system, how much flow there is within the system. If there's too much leak or too much flow, how on earth are you going to get the child to trigger the machine? How are you going to get the child to be synchronous with the machine? Because if they are asynchronous, then you're adding to their respiratory work, and that's really not the goal. That was what you were trying to avoid. And because these things become a problem, many devices just constantly alarm, which annoys not only the patients, but it tends to annoy us as well. I talk a little bit about compliance, and I'm not necessarily referring to lung compliance. I am referring to patient compliance. I was called one day by a lovely junior resident who said, we really need to start some non-invasive on this child. She was 18 months old. She had trisomy 21. And I said, okay, I'll do my best. So the first attempt, I did all the games, all the tricks that I knew. Within about a minute and a half, she'd taken the mask, ripped it off, and said no. It's the only word she knew. She said no and threw it across the room. All right, so we tried it a second time and a third time. And I did have to go back to the physician and say, I'm very sorry, but the patient has refused therapy. And he said, well, how could that possibly be? I said, she's 2, and she says no. There's no way to have a child. This is not, you can't glue the masks and the interface to their face. So you have to be able to convince them that this is good and that this is something that they want to do. It sounds very simple. Even with sedation, we can't always make it work well. Some of the complications, well, because the masks don't fit that well. Obviously, this is an adult, but these types of pressure sores, this is a child, are not uncommon. We are acutely aware of what these look like, and we spend a lot of time trying to prevent these types of pressure injury. We use barrier devices and friction reducing devices. They don't always work. So you need to have a plan. This is not, I don't think this is a good compromise. There are other devices out there. All of these are designed, again, for adults. There are no pediatric versions. There is a pediatric version of the helmet. For those of you who are in other parts of the world, you probably have more experience with it than I do. It has advantages and disadvantages. It's very loud, from what I understand. And in the acute setting, if you had an emergency, you need to actually remove this. So you need to get this up and over their head. But it is absolutely an option if this is what you have available to you. All right, let's continue on. So let's talk about the technical aspects. So NIPPV stands for non-invasive positive pressure ventilation. CPAP stands for continuous positive airway pressure. If you're familiar with invasive ventilation, this is similar to PEEP, so positive end expiratory pressure. We use these terms because they indicate to us that we are in a non-invasive mode. Sometimes this is considered NIV. For those of you who come from a neonatal background, this is not the same as the mode of ventilation that is on a Draeger ventilator. I'm just going to try and clear that up right now. CPAP is what we tend to use most commonly in our cardiac population. It provides a continuous amount of pressure, and we can use it to stent open a floppy airway. We can use it for afterload reduction. We can use it for alveolar recruitment if we're using levels that are high enough. Bi-level support, and I quite intentionally use the word bi-level support, refers to 2 levels of pressure. So an inhaled pressure or an inspiratory pressure and an exhaled pressure, an expiratory pressure. It is commonly referred to as BiPAP. BiPAP is a trade name. Bi-level is the correct generic name. So if you want to look up things in the literature, ensure that you are looking up bi-level, and you should probably get, as a generic term, you'll probably get more hits with your literature search. Ideally, your inspiratory pressure will synchronize with your patient, and ideally it should add to and increase the tidal volume of each and every breath that the patient takes. We would use this CPAP this is why it's used in obstructive sleep apnea, to stent open that floppy airway, it does not per se improve ventilation, whereas this bi-level support helps you clear CO2 and improves ventilation because it makes each and every breath more efficient. All right, so if you like graphs, this is an example of CPAP. As a general rule in pediatrics, we'll start with a CPAP of 5, but we can range up to 10 or 15 centimeters of water, depending on what the indications are. You need to monitor your patient, and you can see a range, especially if you're using it for just nocturnal use, for obstructive sleep apnea, to continuous use. How does it work? Well, CPAP increases your functional residual capacity to expand gas exchange area. So what it does is it helps to, once you've inflated your lung, to open that up some more, and then by giving you more surface area to exchange gas, hopefully you're going to improve oxygenation. By definition, it does not clear CO2, so just remember that. But it can help to stent open airways, so perhaps that might be the mechanism where you have better CO2 clearance. And again, we will use CPAP for afterload reduction. So in general, so this is the technical piece, and I'm going to try and explain it as simply as I can. So in general, positive pressure is a negative effect on right heart function and positively affects the left ventricle. So positive pressure of any sort impedes venous return. It increases afterload on the right side of the heart. I think everybody's very familiar with that mechanism. On the other hand, it decreases afterload on the left ventricle. So it affects preload. It also affects afterload. And what you need to think about is which is going to be the more prominent consequence of your therapy, right? Are you going to impede preload so much that you make your cardiac output worse, or are you going to improve afterload more than you're going to impair preload? In which case you're going to improve cardiac output. So it's a balance. We're not going to talk about ventricular interdependence, but just remember that what happens on the right side of your heart and what happens on the left side of your heart, the two affect each other. We'll keep it very, very simple. We've talked about some of the respiratory mechanics, so I'm not going to get into that, and the respiratory pump. But in cardiac failure, CPAP in cardiac failure, in its very, very simplest form, increases pressure in the lung, which then increases O2 tension in the alveoli, which then helps, it doesn't actually force interstitial fluid into the vasculature, but because you have a greater surface area, it's more likely that you're going to start moving fluid from the alveoli into the lymphatics and into the intravascular space. And by doing that, as you do this, you're going to get a progressive recruitment of your alveoli. The more alveoli you recruit, the more alveoli are available to oxygenate, and therefore you're going to improve your oxygenation and improve your ventilation and decrease your work of breathing. It's pretty simple. Remember though that it does decrease venous return. It does reduce afterload. Okay? It does reduce transmural pressure. So transmural pressure is the pressure from one side to the other across across let's say a membrane. That's not the true definition, but we'll say it is. What it does not do is it doesn't change myocardial contractility. But what you might end up with is improved ejection fraction without an increase in myocardial O2 consumption. This is a big deal, right? So the cost benefit is a pure cost benefit. So let's talk a little bit about how this works with left ventricular afterload. So imagine the proximal aorta is in the thorax and it's subjected to pleural pressure. As you breathe, your aorta is subjected to changes in pleural pressure. So when I take a big breath in, that's also felt on the aorta, which is then felt because the aorta is inside the thorax and the descending aorta is outside of the thorax. The left ventricular transmittal pressure is the pressure difference between the inside of the chamber of the left ventricle and the outside. So that's your pressure. If you do the math, your transmittal pressure is the difference. So your left ventricle is subject to the pressures that it sees when you're breathing. So when you're spontaneously breathing, say I want, so I take a breath in and I generate -5 millimeters of mercury. We're going to just switch up the units for now. When I do that, my left ventricle is contracted, it's generated 90, but now I'm 5 millimeters to the negative, right? And I have to subtract the difference. So I'm going to generate 95 millimeters of mercury. That's my transmural pressure. That's the pressure that I need to overcome to get a blood pressure down on my right hand. When I'm mechanically ventilated, my transmural pressure, this thing here, is less negative, or often it's positive. So my transmural pressure, let's say my left ventricle squeezes, it generates a pressure of 90 millimeters of mercury. But there's already 5, we'll call it millimeters of mercury, of pressure within the thorax. So by the law, just it's basic math, my left ventricle only needs to generate 85 millimeters of mercury to get 90 downstream. There's many ways of explaining this. If you're confused, let me know and we'll go over it again. Okay? When we talk about bi-level, so let me just go back. So when we're using CPAP for afterload reduction, there is a prescription. And remember, this is an adjunct to other medical therapy. And the prescription is 5 centimeters of water of CPAP. Not more, because if it's more, it's going to impair preload, which in turn is going to impair cardiac output, right? So we need to have this balance. When we talk about BiPAP or bi-level, we have to think about things, because what's going to happen is I'm going to have not only a pressure that's continuous within my thorax, but I'm going to have intermittent higher pressures, right? There are different modes that we can use. We can use a spontaneous mode, a spontaneous timed mode, or a timed mode. Those have a rate that's applied with them. But it assists every single breath. This is useful when your primary pathology would be a lung disease, because this is going to assist your ventilation. So it's going to overcome your oxygen or your or add to your CO2 clearance by helping and assisting your ventilation. It promotes the inhibition of the diaphragm because you're helping to do the work for the patient, which in turn will reduce some of the work of breathing. Anytime you reduce some of the work of breathing, it means that your cardiac system doesn't have to work as hard. Okay, but the bigger the differential, the bigger the difference in pressure, the bigger the delta, the more that's going to affect your blood pressure. You're going to get greater variability in your intrathoracic pressure. You're going to get greater variability and greater decrease in your venous return. And hopefully what you don't get is a reduced myocardial, reduced myocardial perfusion. Just to quickly end off, we'll talk a little bit about cardiogenic pulmonary edema and how this can be something that you need to be aware of. So acute pulmonary edema is when you get a sudden rise in pulmonary capillary pressure and you end up with an engorgement of your pulmonary vessels, and you end up with transitate and exudate that ends up in your alveolar space, and in varying degrees, and it's going to manifest itself with a great deal of respiratory distress. The mechanism is pretty simple in that you have a weak left ventricle, you end up with more back pressure, an increasing LV pressure, increase in LA pressure, a pooling in your pulmonary blood vessels. You're going to end up with fluid leaking, surfactant deficiency, poor lung expansion, and then poor gas exchange. But if you just imagine what it's like to have an acute and sudden rise in LV pressure, this is one of the things that can occur. So sudden changes in transmural pressure can induce cardiogenic pulmonary edema. So if you're using CPAP for afterload reduction as a medical therapy, just be aware that removing the CPAP is akin to abruptly discontinuing a medication. When you remove non-invasive ventilation, if the indication for using that is respiratory failure, we've talked a lot about how to assess respiratory conditions and respiratory work of breathing. So if I remove that mask and I look at my patient and their work of breathing increases almost immediately, I can very clearly see that they are still requiring their non-invasive ventilation. It's a little more silent if the reason that you are on non-invasive ventilation is because you are using it for afterload reduction, because you're not able to see that acute rise in left ventricular pressure and that cascade that occurs to give you acute cardiogenic pulmonary edema. And you will notice it when you already are in a situation where a little bit of CPAP is not going to reverse this process. Okay, so in summary, non-invasive ventilation, it's got a lot of challenges for pediatrics. It has challenges for interfaces, for devices themselves. It does improve functional residual capacity. It can help recruit up alveoli. It can decrease, therefore decrease work of breathing. It decreases preload because it impairs venous return because it's positive pressure. And it can also decrease left ventricular afterload. Any questions? Okay. Thank you very much for your time. And our next speaker has arrived.